So we are presenting on a case study from the Massachusetts General Hospital of a 19-year-old man with shock, multiple organ failure, and a rash. So the timeline, about 20 hours prior to his admission to the hospital, he presented with abdominal pain, nausea, and vomiting after eating some leftovers. He was taken to the emergency department by a friend, and there he had weakness, myalgias, chest pain, shortness of breath, a headache, neck stiffness, blurry vision, and purplish discoloration of the skin. 2 hours later, he had very high blood pressure, tachycardia, and tachypnea, so increased heart rate and respiratory rate. And then he was transferred by helicopter to another hospital with a pediatric intensive care unit, PICU. And there he continued to have tachypnea and developed labored breathing, hypoxemia, so low oxygen, cyanosis, hypotension, low blood pressure, and a purpuric rash. So in terms of the clinical presentation, shock, specifically septic shock, due to an infection. Shock can be caused by a number of things, but he had hypovolemia and hypotension and tachycardia. He had multiple organ failure, so he was in respiratory distress and respiratory failure, as well as renal failure. And he had an extensive rash, a purpuric rash on the face, chest, abdomen, arms, and legs, which you can see here. His face is not shown, but the rash was also present on his face, and it was a rapidly spreading rash. So in terms of his medical history, he did have a history of anxiety, depression, and ear infections during childhood. He had reportedly received all routine childhood vaccinations. He did use substances, smoked cigarettes and marijuana, and drank pretty regularly, and also sometimes used diphenhydramine, which is Benadryl, and dextromethorphan recreationally. And in terms of family medical history, his mother had hypothyroidism, and his father had coronary artery disease, and his brother had had viral meningitis at 6 weeks of age, but no complications from that. So we'll move into the differential diagnosis. So sort of the key symptoms that this patient was presenting with include systemic inflammatory response syndrome, SIRS, which is characterized by fever, shock, severe lactic acidosis, and acute respiratory and renal failure, all of which he presented with, and the elevated lactic acid levels were confirmed through blood work. He also presented with coagulopathy, which is impaired clotting, in this case thrombotic coagulopathy, which means excessive clot formation. And one thing to note is that the onset of this illness was very rapid, less than 24 hours from prodrome, which is the first symptoms that appear. So that gives us a number of possible diagnoses: skin necrosis, thrombocytopenic purpura, cryoglobulinemic vasculitis, and catastrophic antiphospholipid syndrome. So skin necrosis is the death of skin tissue. Two types are calciphylaxis-induced skin necrosis, which is caused by a buildup of calcium in small blood vessels of fat and skin tissues. And this calciphylaxis causes blood clots, painful skin ulcers, and may cause serious infections that can lead to death. This is a pretty uncommon disease. A second type of skin necrosis is induced by warfarin, which is an anticoagulant medicine taken to prevent blood clots, but that can cause skin necrosis. It typically presents with a rash early on and causes a rare paradoxical blood condition. So it's an anticoagulant, but it can affect levels of different anticoagulant factors as well and lead to coagulopathy. This condition causes ulcers that can be very painful to touch and usually develop over a number of days. So this patient, these conditions were ruled out in this patient because he was young, not taking warfarin, and had a non-tender distribution of the rashes, which had progressed very rapidly, much less than the time span of a few days that's typically seen with calciphylaxis.
You said 30
Were
years old? How old was he?
19.
19,
Calciphylaxis is typically seen in older patients with chronic renal failure, and this patient did not have a history of renal failure, so these were ruled out.
Okay, so the next diagnosis was thrombocytopenic purpura. So this is an autoimmune blood disorder caused by a decrease in the number of platelets in the blood. This disorder causes lesions on the skin, including easy bruising, petechial rashes on the lower extremities, and this disorder is usually triggered by a viral infection, which the patient did not have. Thrombocytopenic purpura was ruled out because the patient presented with a systemic inflammatory response syndrome, which is SIRS, and coagulopathy, which does not relate to thrombocytopenic purpura. And the next diagnosis was cryoglobulinemic vasculitis, which is also a small vessel vasculitis, which is an inflammation of blood vessels. This disease presents with patchy erythematous rashes, joint pain, stimulus malfunction, fatigue, and is usually caused by an underlying disorder, like hepatitis C. So this immune disorder was ruled out because the patient had no underlying disorder of hepatitis C and presented with SIRS, which I said before was systemic inflammatory response syndrome, and coagulopathy, which does not correlate with this disease. And then lastly, before the diagnosis, was catastrophic antiphospholipid syndrome, which evolves over days or weeks, and is associated with multiple discrete thrombotic episodes. This syndrome is very rare and is seen in an underlying diagnosis of an autoimmune disease. So antiphospholipid syndrome causes abnormal blood clots in the blood vessels or in the heart, and these blood clots are formed in the legs, lungs, kidneys, or spleen, and can lead to heart attacks, stroke, or even death. And this was ruled out because the patient presented with shock and consumptive coagulopathy with hyperfibrogenema, which is uncommon for catastrophic antiphospholipid syndrome.
Okay, so the diagnosis was purpura fulminans due to meningococcemia. Meningococcal meningitis is an infection in the thin lining that surrounds the brain and the spinal cord, and a blood culture confirmed the presence of an meningitis serogroup C. Further, purpura fulminans is a thrombotic type of dispersed intravascular coagulation commonly associated with an infection, and it can be seen in the body through reticular rashes, skin mottling, elevated lactic acid levels, low levels of endogenous anticoagulant protein C and S, and low antithrombin levels. So antithrombin and protein C repletion were the large parts of the treatment for this patient. PCC is prothrombin complex concentrate and was chosen as the protein C source due to accessibility. And plasma-derived antithrombin concentrate was used for the antithrombin repletion. This treatment was done immediately due to the rapid decrease in benefit after 48 to 72 hours of initial symptom onset. And then therapeutic anticoagulation was also used in the form of heparin. Heparin inhibits coagulation, and it was administered intravenously. So this is a figure that is showing how protein C facilitates the anticoagulation process. Basically, thrombomodulin and thrombin form a complex that also includes protein C and protein S. And when protein S joins the complex, it activates the proteolytic site of protein C, which then inactivates the cofactors in the intrinsic and common pathways. The inhibition of these pathways leads to a decrease in fibrin production and coagulation. So when there's a protein C deficiency, as there is in this patient, the thrombomodulin and thrombin complex are not able to inactivate the cofactors of these intrinsic and common pathways. And this increases cofactor levels, increasing coagulation and causing a greater risk for blood clot. So for management and treatment, for shock, fluids were administered, as well as norepinephrine, vasopressin, and epinephrine to reverse hypotension. Dextrose and calcium were also used to combat this hypoglycemia and hypocalcemia. For the respiratory distress, the patient received tracheal intubation to better promote oxygenation with lung protective mechanical ventilation strategy. For renal failure, a hemodialysis catheter was placed due to anuria and renal failure, and continuous hemofiltration was used to achieve a negative fluid balance. And for cardiac dysfunction, a temporary transvenous pacemaker was placed. As for the outcome for this patient, unfortunately, the patient received bilateral below-the-knee amputation, as well as amputation for parts of all of his 10 fingers. In regards to his renal and cardiac issues, the pacemaker was removed and hemodialysis was discontinued. And finally, for vaccination status, the patient had received only 1 dose of the meningococcal conjugate vaccine. He had no booster, and 1 dose of the serogroup B meningococcal vaccine.
As a child?
Yes. And that is all.
Vaccines, kids.
Yes.
Jesus.